So the first point I would like to make is that we should stop talking about ovarian cancer, because ovarian cancer really doesn't exist. There is cancer on the ovary. And most of the cancers that we see, I don't know if all, but most of the cancers are immigrants to the ovary. They didn't originate in the ovary, but they migrate. So we should stop talking about cancer of the ovary and start talking about cancer on the ovary, because it's going to change our whole mindset on how we treat those diseases. So conflicts of interest, not really. I've already said that. So what I wanted to, the objective of this talk is going to be basically to present the role of MIS in general in ovarian cancer. And you're going to see in laparoscopy it's going to be a very quick discussion. And then I would like to see how, by introducing neoadjuvant therapy, we might maybe start seeing a shift in the paradigm of how we treat those cancers on the ovaries. And we'll look at the clinical outcome of what we have done in robotics. So for me, when I think about the paradigm of ovarian cancer, I see a tripod on which we need to improve the value of treating ovarian cancer. One of the feet of that tripod is going to be translational research. There is no doubt that we've reached the limit of what we can do with surgery and with chemotherapy in ovarian cancer, and the answer is going to be here. Now with that, if the translational research is going to get better, then the surgery will be able to become smaller and smaller. And that's where there might be a role for MIS and robotics, more specifically, that those two go hand in hand. Still, we need that third arm, and that third arm is going to be making sure that we look at our outcomes and see if they are better. So if we base that little chair on those three legs, I think we're going to get further. So what did SGO think about robotics for ovarian cancer? This is their statement, 2012. Only a few isolated cases have been reported. It's true. Currently, early stage disease may be more amenable. That's what they think. So when we put that in balance, I don't need to convince you very much, but what are the advantages of minimal invasive surgery? We really know. What are the disadvantages? We kind of know them too. So it's within this context that we need to start thinking, is there a place for robotic surgery? So after this brief introduction, the first thing we should do is, what have we learned from laparoscopy? And as I told you, it's going to be very short. Why? Because there is not very much. There is data on laparoscopy in early ovarian cancer, and you could see that out of the studies, and there are not that many, a lot of them are borderline tumors that are really not cancers. We could see basically, I was kind of surprised about, so that's about that. I was kind of surprised to see the complication rate that they had in laparoscopy, which was more than what I would have expected for early ovarian tumors. And then the length of stay, which seemed to me to be extremely long. For totals, overall, in the literature that I could find, of 144 cases described undergoing laparoscopy. A few studies have compared laparoscopy to open surgery for a total of 54 patients. So basically in the literature we have 200 patients who underwent laparoscopy for early ovarian cancer. Now for advanced ovarian cancer it's even worse. One paper in 1996 on 5 patients, one in 2005 on 25, and one in 2010 on 32. Now, the 5 here included secondary cytoreduction, so they were not primary. The 25 here were about hand-assisted laparoscopy, so not full laparoscopy. And the 32 here from the NESAD group were in stage more than 2C. I'm not sure how many of those were really advanced. So not a lot of data on laparoscopy. So what do we know about robotics? Well, not very much more. There is that study from Magrina, which is a really interesting study, where they took 25 patients from 2004 to 2008 and compared them to laparoscopy or laparotomy equivalences. So they had 15 type 1s. Type 1s are straightforward debulkings. Type 2 debulkings, they had 8 patients. That is one major procedure in addition to the regular which is either a bowel resection, a full diaphragmatic resection, a liver resection, or a spleen resection. That they call the type 2. And then the type 3 was if you had more than two or more of those procedures. So in the type 3, they only had 2 cases. They compared them. They said type 3, Magrina said, forget it. That's really not worth doing by robotic. Type 1, sure, the data is better than laparoscopy or laparotomy. And in the type 2s, it's really borderline. If you need to do those things, maybe you shouldn't. But you could see not very much. Foyer came out with his study, which was not very enlightening, but ultimately what he said is that compared to laparotomy, do robotic surgery, it's possible. The operative times were, by what he says, reasonable. Hospital stay and blood loss were reduced. And on his 1-year survival, he found the same recurrence rates, 1 year. So really not very much. We started our study, and we have accumulated 64 patients with pelvic epithelial cancer, which includes fallopian and primary peritoneal. Half of them had neoadjuvant chemotherapy followed by robotic surgery. Half of them had primary debulking. These were the patients, so half of them neoadjuvant. Obviously, in that group, we had 30 of the 33 had advanced stage, 3C or 4. And in the primary debulking surgeries, of course, we had less of those advanced cases. The division of cases is what you would have expected. Nothing that I can really teach you here. So this is the data. Age of patients. This is not a comparison. Let's be very clear. This is not a comparison between the 2 groups, but I give you the data of the 2 groups separate. Not because we did anything, we expected something different. You could see the BMIs are similar in the 2. Patients with an ASA above 2, about half of the patients in each. Surgical time was actually similar, whether it was after neoadjuvant or in the primary debulking. And then length of stay was 2.6 days. Half of the patient in both groups left the hospital within 24 hours. So this is after major debulking for ovarian cancer. 3/4 of the patients left the hospital within 48 hours after major debulking. Complete cytoreduction rate, 21 out of the 33, 24 out of the 31, which is, I think, a reasonable result for debulking surgery in ovarian cancer. We could see that after neoadjuvant chemotherapy, those who we couldn't get complete cytoreduction, at least they were debulked to less than 1 centimeter, which is not what we want, but at least it's somewhere we can live with. If we couldn't do, after neoadjuvant chemotherapy, a better debulking, and those are patients that we didn't feel that if we would convert them, we would get further. Okay, blood loss, obviously way less than you have in open surgery. And then we had some complications. So we had 3 enterotomies here that were treated robotically. Cystotomy also treated robotically. We had 1 vesicovaginal fistula after neoadjuvant. Her tissues were really extremely friable, and she developed a vesicovaginal fistula. Vessels injury, we had 2 in each side. They were treated robotically. Conversions, we had in both groups conversions. 2 because of massive disease. That one requested basically a conversion at the time of laparoscopy. We said there's no way. And 1 later on because she needed a low anterior resection, and we didn't feel comfortable doing that by MIS. And here the same thing. 2 had rectal invasions, and we converted, and 1 had massive disease. Lymphocyst, but not very important. We had to reoperate 2 patients in this group. 1 is the one with the vesicovaginal fistula, and another one was with a bleed, which was different than those 2, which was found post-op. No much explanation. And then here we had 1 patient with a bowel injury. This is the patient that ultimately died of sepsis because the bowel injury was not noticed during surgery. She was 84, and there was, by the time 48 hours after surgery, when she developed the sepsis, we couldn't recuperate her. This is the survival data. We compared 1 to 2, so we took 2 laparotomies for each robotics in our historical cohort to compare them. And what we see is that the robotic cohort at least didn't have a worse survival compared to the equivalent who had laparotomy. We then divided it up in the primary debulking and in the neoadjuvant, and we found the same image, so it's not in one group or the other. Where we did find differences, if we took the stage 3C patients only, so just to homogenize a little bit the population, then in the primary debulking surgeries, the robotic did better, but it was not statistically significant compared to the laparotomies. However, in the neoadjuvant, it was statistically significant that the robotics did better. This is probably because of somewhere a case selection that even when we tried to match, we didn't match well enough. So we developed some guidelines at our hospital for which patients with ovarian cancer can have robotics. The biggest tumor needs to be able to fit in a bag. If not, we don't start the minimal invasive procedure. And we do a full laparoscopic evaluation before we decide to do robotics or to convert to open. We talked a little bit about port site metastasis this morning. I just want to go back to that a little bit. We had one port site metastasis out of the 64 patients, and this was at the time where she recurred and had concomitant full carcinomatosis. I must say that in no of the diseases that we have treated by MIS, laparoscopy, or robotics have we seen single port site metastases. It was always associated with disease elsewhere. So the single site, it was never a single site, pure port site metastases. The data from Sloan Kettering is pretty interesting. We saw that this morning already. They had 20 port site metastases out of 2,000 about, which is 1.2%. 15 out of those 20 were in ovarian cancer, and 19 out of the 20, similar to what we had concomitant carcinomatosis, so it did not influence the prognosis. So we need to be really getting one floor down and relax about port site metastases. I don't think it influences the prognosis of the patients. So how do we interpret what I just told you? First of all, we need to be extremely cautious in our interpretation. It is feasible in selected patients, both for early and for late disease. You just need to select the patient that can benefit from it well. We have an acceptable complete cytoreduction for stage 3C patients of 70 and 64%. I think that you don't get much better when you do it open. The conversion rate was 6 and 10%, which is acceptable. I mean, I showed you which ones we decided to convert. It's not because of complications. The complications was a different issue. And the short-term oncological outcomes were at least as good as the historical cohort of laparotomy. So we don't do something bad by doing this, but we need to remain extremely shy and humble with the very limited data that we have and with the bias of the surgeon choosing his patients. This brings me to rethinking the whole paradigm of ovarian cancer. I had the chance to talk with a few people yesterday and today, and maximum cytoreduction. This is what, what's going on in the United States. Well, the first thing is we should never compromise on complete surgery. That should be our gold standard. Complete cytoreduction, no compromise on that. Whether you do it open, laparoscopically, or robotic, that should be your goal. But considering that, there's going to be an array of patients that are going to benefit from the advantages of robotic surgery or minimal invasive surgery, and there are going to be an array of patients that are going to benefit from laparotomy. And this is going to go in the direction of radicality. The more radical you're going to need to be, the more you should go to laparotomy rather than minimal invasive surgery. However, the question really is whether or not neoadjuvant chemotherapy can shift that curve towards the left. So you're going to have more patients that might benefit from minimal invasive surgery compared to maximum cytoreduction. And if we go back to our tripod about this, I'm just wondering if there is not a shift in the paradigm of value from that primary ultra-radical debulking a la Dennis Chi or a la Bob Bristow versus the advantage for the patient of neoadjuvant therapy followed by MIS, where they won't have all of those morbidities, ICU stay, and mortality that we have seen in those studies. So with those ideas I leave you, and thank you for your attention.